Hi, I'm Steve Scanlon, RN and paramedic, and today we're going to be covering the intraosseous catheterization of our patients who are more than likely in cardiac arrest, but we can also use it for the unconscious patient who needs rapid fluid resuscitation, for instance. And today we're going to be introducing all the instruments and the skill. Alright, so now I'm going to show you all the various tools that we're going to be using for the skill. First we need our drill, our IO drill. It's called the Easy IO. It's pretty much the same as any drill you get at Home Depot, only it's medically clean. It's got a hexagon drill bit in the center there, and it's made to fit any one of these needles. It usually comes in a package such as this. It'll come in with a needle of various sizes. They come in bariatric all the way through pediatric. It'll come in with a 4-inch extension set and usually a mini sharps container, but we'll always put our sharps in a larger sharps container because when we're traveling around in a bumpy squad, one never wants a needle stick, of course. So we'll need a 10 cc flush. We'll need our normal saline, lactated ringers, whatever IV fluid we're going to be using. Our IV line, of course. We'll need our alcohol preps or some sort of chlor prep to prepare the skin. We can use a commercial securing device for the IO needle, or we can use some tape or some gauze. It really doesn't matter how we secure the device to the patient, whether we're using the commercial device or we're using gauze, but it is important that we do secure the device to the patient. It's important not to get a false sense of security that just because the needle is anchored into bone that the needle is not going to move. The catheter is still prone to moving just as any other catheter would be. Okay, well, let's get ready to show how we're going to place the catheter into the bone, proper placement at the various landmarks. Okay, so we're going to explain how we would perform the procedure on a patient's leg bone, specifically the tibia. This is a model of the patient's left tibia. And we have a patient who's in cardiac arrest. We can't get peripheral vascular access. So the doctor orders a IO to be placed, or if we're in the pre-hospital setting, our protocols state that we can place an IO catheter. So we're going to place that. First, I need to prep the site, and I'm going to take my alcohol prep, and I'm going to aseptically clean the site. And I'm going to look at the patient's kneecap, and I'm going to palpate below the kneecap, and I'm going to find the tuberosity of the tibia. The tuberosity is an articulation point for the tendons and ligaments, and it's going to feel like a bump. And once I feel that bump, I'm going to go about 2 finger lengths below that bump, and that's going to be my landmark. That's where we're going to place the catheter. And once I feel that, since I've touched the patient again, I'm going to again clean the site. I'm going to take my drill with my catheter attached, and I'm going to place it into the patient and drill. As soon as I feel a pop, the catheter is deep enough, I'll remove the drill, and I will unscrew the inner cannula, and I will put that into the sharps container. At this point, I'm going to put on my extension set, and I will flush. And at this point, I can put on my extension tubing and flush medications through here, fluid resuscitation. I will address the catheter, affix it to my patient, again with the commercial dressing if I need to. I will, or I could use gauze. At either is fine with me. And that is how we would address it to the tibia. So we've covered putting the IO catheter in on the tibia, but the preferred site nowadays pre-hospitally is actually in the proximal humeral head. 88% of IO insertions on your first attempt doing this as a novice placement are successful, and putting it in the humeral head has almost the exact same medication delivery to the heart as a central line. And I think we can all agree that central line placement takes quite a lot longer time and effort to do, with perhaps a less successful rate of placement, especially first time, than IO. And plus it's out of the scope of the paramedic to place a central line. So humeral head can save lives, and it's very fast, easy, and it's gaining a lot of popularity. So I want to talk a little bit about how to properly place this in the humeral head. So we have our mannequin here, and we can see our humeral head. Now it's very important that our patient, we have our patient's arm crossed over their abdomen like it is on this mannequin here. And now we're going to show you how to place your hands so that way you can get the humeral head specifically in the spot that is necessary. You need to get it on the greater tuberosity of the humeral head, which is right here. If you don't, there are several ligaments, nerve endings, arteries that you could hit, which could severely damage the patient. So it's important that you get proper placement the first time. Okay, so we have our patient lying on our cot or on our hospital bed, and we have, as illustrated earlier, our patient's arm crossing their abdomen, And what I want to do is I want to take in this orientation, I want to take my left hand and place it right in between, in the armpit of the patient. Okay, and I want to take my right hand and put it perpendicular to my left. All right, and I want to take my thumbs in the center. Okay, and in the center I'm going to feel a bump. Okay, and that's the greater tuberosity of the proximal humeral head, and that's my landmark. That's where I want to hit. So as soon as I know where my landmark is, I want to remember that. Okay, I'm going to note where that is, and I'm going to take my alcohol prep or chloroprep or whatever aseptic cleaner I can use. I'm going to clean that, and then I'll take my IO drill and just as before, put it in the sharps container, safety first, and I will take my commercial dressing and I will connect my tubing. And here I go. So that's how you put in a intraosseous catheter on your emergent patient in the pre-hospital and hospital setting. And I hope you've learned something, and thank you very much.